the need to get back to patient care and other things. All right, it is my absolute pleasure this afternoon to have the opportunity to introduce you to Dr. Norman Wetterau. Dr. Wetterau is the president of the New York Society of Addiction Medicine. He currently serves as the Society's chairman of the Family Practice Workgroup and is liaison to the American Academy of Family Physicians. He's also the representative of Patient-Centered Primary Care Collaborative, program committee member for the annual Medical Scientific Conference, and the past member of the Society's Strategic Planning Task Force. He's here today to talk to us about ISTOP. This is being recorded. We hope that you will engage in a dialogue. We had a rich dialogue this morning between over at East and the North, and so if you'd all help me, welcome Dr. Wetterau.
Thank you for coming at lunch. I know that you probably have a whole pile of calls and things to do. You're putting on. So I'm a family doctor in Dansville, part of Track Over-Prescribing medicine. So the last couple of years I've gotten more in addiction medicine because I've had an interest and I've gotten involved politically, state organizations, and international. But I've been on the board of State Academy of Family Physicians and good friends with Phil Kaplan and some other doctors here. So we're going to go over this, and we're going to may skip a few slides too. We had a good dialogue this morning, but we're going to skip a few things. So let's look at the second slide. Is just to acknowledge that a few of these slides, not many of them, I did borrow from the state, not very many. And then the next slide, basically ISTOP is the internet system to track over-prescribing. And when you think, you've probably heard of ISTOP, how many have sort of a favorable thought about ISTOP when you think about it? And how many sort of have an unfavorable? I don't think you're being honest. Most people, they're sort of scared. They've heard some bad things. So we're going to cover both of that. They're just being polite here. The next slide is, this is what actually ISTOP is. And it's really a very good thing. You're going to be able to go online, really within a couple weeks, and you're going to be able to put the patient's name, the birth date, and the sex, and you will be able to obtain a list of all the controlled substances they've gotten prescribed within the last 6 months. Now, may not, I think that may be a little delayed and so on. And they'll be updated right away. They'll be put in the system every 24 hours by the pharmacist. And so you will know. And you'll know who prescribed them, the dose, how many, what pharmacy they got them at, and how they paid for, insurance or cash. So that's going to be very, very helpful for all of us. And it's going to take a little time to go online to find that out. But think about new patients that come into your practice, and you're trying to get information. You know, you write for records, they never send them. You get on the phone to call the doctor. You're on hold, this, you know, at least I find that very burdensome. We still need to get on records, don't get me wrong. But it's very hard to get it at the time. And then even your own patients, you don't really know. They went to the emergency room, what's going on? And so now you're going to know right away. Every time they come in, if they're going to get a prescription for a controlled substance, you're going to have all that information. And it's going to be very easy. So that's going to be very valuable. And I think it's also going to be valuable because once patients know that everybody knows that you've been doctor shopping, they're going to stop you. You know, they may not be totally happy with what you're giving them. Maybe they like to get some more, but they take a risk that if they go get some more, they may not have any. All the doctors may say, I'm sorry. And it's not that, once that word gets out, you know, oh boy. So I think this is going to be very valuable when managing. And then you'll know what doctors they saw, you know who to write for records. Because I'm sure, you know, I've had patients that no one ever writes for them. I'm sure they don't give my name. They don't want them to know they saw me. That they were selling the medicines or something. They don't want them, they're not going to know that. So now they're going to know that I gave them a prescription. What did you see Dr. Wetterau for? Well, nothing. I saw you've been seeing him for 4 months. I think we need to contact him. Okay, so that's what ISTOP's about. So now why did we get, this is a law, you know, and that we're going to have to go into this. And so how did this come about? In the next slide, we have a medical problem, and that is overdoses. So, I want you to think, HIV deaths are about 10,000 to 12,000 a year. And then down here is homicide. And up here is firearms and suicide. And then up here is motor vehicle. But look at this. And now it's even higher than motor vehicle accidents. Oops. We have a little water accident up here. That's not a smart move to leave my water there. Anyway, so that's the, so this has been an epidemic. And I'm very passionate about this. That these are young people that are dying. We spend so much time keeping older people alive, and I'm getting older, so I hope somebody wants to try to keep me alive. But when somebody dies in their 20s, it's really upsetting. And think for a minute about all the patients in your practice, in your career, between 15 and 35 that died. And probably, hopefully not very many of them. How many of them it wasn't in some way related to alcohol or drugs? Either they're all used for somebody else's. You know, in my life, I have only a couple. I had somebody that died of Hodgkin's at age 23, and I have a couple. But most of them, it's related. And this is a really upsetting thing. And this is a lot of deaths. You know, influenza epidemic, 25,000 deaths, mostly older people. This is an epidemic. You know, think how much time we spend on influenza. Think of all the, you know, this is a crisis. This, these are addicts. I'm sorry, they're people. And there are many of them, you know, they could be your kids, your neighbors. And a lot of them are not even addicts. Some of them are just kids having a party. A few Oxycontin, a few Xanax, a few drinks of alcohol, and they don't wake up in the morning. So, you know, when I asked this morning, is any of your patients, you know people that have died? How many know somebody that's died of an overdose? So it's really common. And how many know somebody that died of influenza this winter? And these are the people. And how many people, the person that died, it could be older, but most of them it's younger. Usually if it's older, you don't diagnose it. You put down COPD or something else. It's sort of not known. We won't get into that. So that's why this is a problem. All right, a couple of quick slides. The next slide, you know, we talk about what the cause is. There's many causes of youth drugs and, you know, and why kids do this and why young adults and addiction and so on. And those are all those causes are true. I could probably give you 15 causes. But I'm going to give you, it sounds simplistic, but it's actually very important. One of the big causes is so much stuff floating around. It's as simple as that. So here is the deaths, and here is the sales over the period of years. More sales, more deaths. And you say, well, that's not good research. But then skip a slide, go 2 slides. Oh no, I'm sorry, go back. This is oxycodone consumption in New York State, just to give you an idea. 96, next one. Hydrocodone, 80% of all opioids used in the world are used by Americans. Next, and prescribed by us people. Next, all right, we're going to skip this map just for time and summarize. Basically, it isn't nationally, as the sales have gone up, so has the overdose deaths. But if you look at the states that have the most sales have the most overdose deaths. And so one of those maps, you know, but I'm going to, just for example, New York State is not the worst. 5 kilograms per 10,000 people in 2010, 8.4 deaths. 100,000, well that's a lot. I don't know about in Rochester, Greater Rochester, that would be about 100 people. Syracuse maybe a little less. That's a lot of young people dying every single year. More than gunshots, more than most others. Tennessee, 11.8 grams, almost twice as much, 14.8 deaths. And you can look at all the states and start studying them, and you see this correlation. 400% increase in New York State in deaths from 99 to 2010. So one of the main causes is how much is being prescribed. It's not the only cause, it's one of the main causes. And so we aren't going to blame Mexico on that, or we're not going to blame, you know, they get plenty of blame, but not for all of this. This is partly us. Next slide. Okay, that's how much increase in New York City. And you can see 65%, Staten Island 261. And actually the reason this law got passed, it isn't because inner city kids were dying. So when kids in Long Island that were going to Harvard Ivy League schools started dying, and certain people out there demanded something be done. And those are the state legislatures that said we have to have legislation. And maybe it's a little overkill, but the Medical Society did drag its feet. And so now we have this. So I think as a whole, it's good. but it does have some issues, which we'll get to. All right, next. So, what do we do? What does the CDC recommend for this epidemic? And there's many things, but I wanted to just, number one, the prescription monitoring program, which is really what an ISTOP is. Going online and knowing that that's a high recommendation for this problem, okay? And it will work. It's an evidence. It's not going to get rid of it, but it will help. The second, then this last one, I want to talk about that for a little bit. Better access to substance abuse treatment. That is really, really important. You know, unfortunately, when ISTOP first comes, you're going to have all these people that can't get their opioids. So the problems are going to get worse. And maybe more heroin, I don't know. But also with the ISTOP, you're going to get less people getting addicted. And you also won't have kids getting into medicine as much. There won't be so much floating around. If you do have a group of addicts, and you can just tighten them and threaten them with prison and everything else, then it isn't going to, it doesn't solve their problem. So there's a group of people that need treatment. And so that needs to be one of the major things, getting people into treatment. And even the purpose of ISTOP isn't to catch people, isn't to throw them out of your practice. The purpose is to, first of all, don't prescribe unnecessarily, and to discourage people from doctor shopping, but also to find people that have addiction problems and get them treated. You really help them. These people are desperate. You know, you're upset about them, they're upset about themselves. I have 100 patients in Suboxone, and they hate their addiction. Heroin addicts and opiate addicts hate their addiction. Alcoholics don't all hate their addiction, and I think in marijuana people say, well, I just do this for fun, for my health, excuse me. But heroin, opiate addicts is sort of, they aren't honest about everything, but they're usually somewhat honest about their problem. And it's a real problem. They don't know what to do about it. So get them help. You can really, really help. If you have somebody that has cancer, you can help. You call around. Get them in right away. They have cancer. Well, how about this? This is, you know, these are young people that are going to be dead. Now, one of the best treatments is Suboxone. And I understand there's only one doctor here that prescribes Suboxone. Is the doctor here?
No, Dr. Martin.
Yeah, okay. So I really would highly encourage some of you to think about Suboxone. You can at least prescribe for your own patients. You know, it's very easy. You go online, you take an 8-hour course. They have a mentoring system if you need a mentor. They can call on the phone. You hardly need one, but they have one. You're all nervous about it, you know. And if I told you there was a new diabetic medication that will get rid of all insulin and all hemoglobin A1Cs, would go down at least 2 points, you would all be using it. But here's a medicine that saves huge numbers of lives. If people want it, they don't die, they don't get HIV, they don't get hepatitis C, they don't get arrested, and most of them go to work and earn money. And I have 20 women that went through their pregnancy successfully. The babies, there was one baby, there was one problem, but it wasn't related to Suboxone. But they weren't taking cocaine, they weren't out in the streets, they were just taking exactly what was prescribed. But the best news isn't just that, and the babies had some of them, about a third of them had some withdrawal. But I'll take healthy babies that have withdrawal over, you know what, everything else can happen. But the real good news is 18 of those 20, the kids still live with the mother. I think two of them have 2 kids. One came in the office, 6 years old yesterday. So this is, but without this, they would have been in foster care, mothers in jail, it would have been endless, you know, millions, just my 20 patients would have been millions of state money, and millions to keep them locked up, the foster care, and the this and the that. Then the kids are in school, and you can imagine all the problems there, and it would be unending, unending, unending. So my Suboxone is really, really, they got Constant and they got other things. There's not enough doctors to give Suboxone. There just isn't. I have a patient from Syracuse that moved from Rochester. I can't find anyone. So I really would encourage you to think about it. It's a wonderful medication. Go online. When you take the patients, they do take a little more time at first. You need a half-an-hour appointment, not 15 minutes. But and you can get them some counseling and just help. So really, you could, some of these are your problem patients, because it also helps pain. So these people that have pains and this and that, it's just a really, really good alternative. And I do not get any, I've never taken a penny from Rickett. for any speaker fees or anything. I'm not connected. I don't own their stock or anything. I just know people are desperate. I had a patient who came in, they were one of the best friends died. They were trying to get some oxygen, they couldn't. And this was a month later, they tried. We couldn't take them, we didn't have any openings. And dead. And that goes on all the time. So think about it, go online, on ASAM's web, look it up, take the course, and do it. Okay. Any questions? Thank you. I want to really hit that, because what are you going to do with these people when you see them? If you all doing it, then doesn't mean somebody has 100 patients. You all have 5 or 8 or 10. You just keep that in your armamentarium. The other things you can do are a little bit, not in New York State, but some places are accountability, restriction, and Oregon, you can't prescribe more than a certain amount without a consult. That's not in New York State. But there are quality assurance things you can do, and there's things the insurance companies could do if they wanted to. You do, how often do you do your drug screens? And I understand you're doing that. You're ahead of the game. You people that are on chronic opioids, you do your drug screens. Congratulations. You're above average. All right. Next thing. We'll get down to some of the. So, any questions? Quick. Now we're going to get to the ISTOP. The bill actually had a lot of stuff. ISTOP, electronic prescribing, and so on. We may not, safe disposal. So these are all the things. We may not get all of them. But next slide. So this is what we told you before, what ISTOP is. That will give you all these drugs, dose, quantity, and everything. Now, you have to go to the Department of Health site. And I was meeting with several of your nurse managers for about an hour and a half. And we had a great meeting, so they have all the answers. Not really, but they can help you. And if you probably are already registered. If you have gotten controlled substances in the past, your prescription pads, and you get state prescription pads, you're registered. Now your password is probably expired, unless you've used that site in the last 90 days. So, but you may have and I didn't realize that you have different sections. So some places, one of the administrators have you all registered. In other ones, the doctors. How many of you know you order your own prescription pads? Okay. So you're registered. Is your password up to date? Probably not. Really? You people are great. Okay, well most of us are going to have more trouble. In our practice, we have a secretary. She takes care of all of that. Reminds us and everything, or else we'd be doomed. The nurses are registered because they're in the immunization. So the site's there, but you're going to use that site. And what we talked about is in your different groups, who's going to manage this? Probably somebody, whether it needs to take a little charge of this ISTOP and make sure everybody's registered and everybody has a password and knows how to get in to get this information. It's not quite set. They've been promising me since in early July. I hope it is. All right, so that's where that is. On the next slide, and this is the kind of information you'll get. If you go there now, you don't get that. Right now, it's very unhelpful. It says, well, this patient's at risk. And now exactly how many medicines, the quantity, where they get them, everybody can prescribe them, including your own. And it will be helpful even for you, so you know exactly what you've given them and when. Okay, next. All right, now comes the big news. Beginning August 27th, practitioners must consult the registry in most cases, almost every case, prior to prescribing or dispensing any controlled substance listed in Schedule 2, 3, or 4. So every time they come in, you have to go online and you have to check. And that includes, like tramadol is a Schedule 4 now. It really includes almost everything. And so that's really sort of a problem. I think. I'm busy. I think, it's going to be, oh no. And you have your electronic record, and you got to minimize it and go onto another site and put the name in and the birth date in and so on. So I do have a solution, which is in the next slide. I'm sorry, that's I think where we are. We tried to get the law delayed until you get a real time. If we could just click on the electronic record, the name in the corner, and get onto that site, and immediately takes you over, then that's going to be a snap. And they're going to have that. but not by August 27th. We told them that, but anyway, you know how that is. Yes?
To your point of real time, when I was doing a literature research on this, though, it was saying that our doctors have to put in the medication at real time.
No, the doctor does not have to put in the medicine.
That's not going to be the case?
No.
Okay.
No. The original law, that's what they originally proposed.
Right.
That was changed.
Okay.
There's been a number of changes.
Okay.
When I think of the serenity prayer, we have to accept, but we need wisdom because we can change some things. And that's sort of what this is about. You can change how your office is organized, how you do things. You can make it easier. You can't eliminate it, but there are things we can change, and we need wisdom to do that, individually and in the group, as you think about it. And that's what I talked to some of the group nurses individually and in the group separately from the talk. We were just chatting about and each group will be a little different. And you need to have input to make sure you're together on this. So you don't have to do that. All right, let's go to the next. All right, assuming the regulations are approved, which I think they will be. They're waiting to the last minute. This is really not, I don't like that. But number one, the staff, other than providers, can go online and check. So you can have other people that are designated, secretaries, nurses, others, that can check for you. So you don't have to do it yourself. So that's a big thing. They have to register in your name, under your name, with their own registration number, but under yours too. So they're going to go in as your proxy, and they're going to have their number. Now the reason their number's there is the computer system then will know that somebody's queried the system for this patient. And if there's any breach of confidentiality, suppose somebody, queries the mayor and then spreads it all over what they're on. Well, they're going to know who queried the mayor. There's a number for that. Okay? And so confidentiality is really, really important, and it can be tracked through this.
So if
Yes.
someone's your proxy, are you responsible for what they do?
Well, you're responsible, but you can fire them, and
But
yes, you're responsible for your proxy, but they know who did it, and that's certainly they're not. I don't think they're going to pull your medical license when they go online, and also the staff. The practice can fire the person and take.
But ultimately, you're responsible for it.
You ultimately you are, but you're certainly much less responsible than if it was only under your number. They didn't know who it was. I can be wrong, but I just can't see them going after a doc. Now, if you get the information, they hand it to you and they say, look at this is so-and-so, and you go walking down, this is our phone, everybody. Look at this, they're on 5 different doctors. And so you're responsible. But that second, I know what you're getting at. I think they're doing this specifically to try to keep the responsibility of the person. They're afraid that secretaries are going to start mining for names and spreading the information.
I wouldn't have someone go in who's not licensed, either an LPN or an RN.
I agree.
What?
I would agree
I
with you.
would not have someone go on my license as my proxy who's not an LPN or an RN.
You'll have to make a decision about what you want to do. I think our group is
I don't know if you'd understand how large this practice is you made, but I gotta tell you, there's a lot of eyes and a lot of things tapping on keyboards here.
So you're going to have to make those decisions, and I can't make them for you. That's what we, and actually I think one of the nurses there told me, I learned something from my discussion. The nurse is supposed to preview all of the patients before they come in, and they can know which ones are likely to leak controlled substance. And I said, no, that's great. I said, I don't think we can do that, but I'm going to try. Then I learned something that some of you have 2 people for one position.
Correct.
We don't, we have 1. So with 2, you should be able to do that. That's a big help. That should help you a lot. So I think you probably do okay, but you have to figure that out. How that's being done. Our group is a little we don't have that, and so we probably would have a secretary. What we want to do is everybody in the morning will be checked by somebody. That's what we'll probably do. I think what you're going to do will be better. At least what I listen to the nurse, and I don't know. I'm going to go back and say we need 2 people for each stuff. We really do, because our nurses just run ragged. The person that assists all of us are medical assistants. So that's something that every system is different.
This is
okay?
it's untested water, so
Yeah.
there's going to be a lot of
Yep, some of us are going to get a few bites on our necks. And, yep, so hopefully it's not a poisonous snake in the water. It's just a water snake. We'd be able to check up to 30 names at once. That's the other thing. And so, go to the next slide. Okay. So I think you have to figure out the system. What we are hoping to do in our office, and it may not work, and you know they're putting this off to the last minute, so they're not giving us much time to figure this out. But we're hoping, we believe we can put our names from their EMR onto an Excel sheet and transfer it into their system, and all the patients can be checked by one person. And then we'll have that information printed out for us when we see the patients. But it may not work. And if it doesn't work, I don't know what we're going to do. With one nurse and one doctor and all this stuff, it's going to be a real inconvenience. But we'll figure, everybody has to figure it out for the group, depending what the group is and so on. But whoever does it, educate them and make them realize it's important and that it's confidential. And we're going to have to get through this. I think in the long run it's going to be good. In the short run, it's not going to be. There's exceptions. I don't want to go through all of them. You know, methadone programs, ERs can give a 5-day supply without checking the system. But your urgent care, I don't believe, is a certified ER. It's part of your practice. So I think you're going to have to check. I'm pretty sure. Hospice, you don't have to. You have the notes here and that. And technological failure, but it has to be real technological failure. You can't say, well, I'm sorry, I'm 60 years old. This is technological failure. You have to have a real failure.
No longer will be able to, in an office-based practice, give a 5-day cover. No longer.
If you check online, yes. Oh, it's an emergency. If you're on call at home, which is, I don't give controlled substances when I'm on call, but you will be able to, and a house call. If you make a house call and you need a 5-day, there are some, for an emergency, you can document this as an emergency and you couldn't get to the system. Either the system was down or you're making a house call, then you can do that. And you're exempt for that.
So office-based physicians can still do a 5-day emergency at their discretion?
No, not if they're in the office.
That's what I wanted to know.
Yeah, no, not if you're in the office and you have access to the system. The system is down, but if you're at their house or someplace else, then you could do that.
Okay.
Okay? There's not a lot of exceptions, but there are a few. All right, and if you're giving them the medicine from the office staff, stock, you don't have to check. But you send a prescription home. So if they're in the urgent care center and you give them a dose, a shot of morphine or something, you don't have to go online. But if you give them a prescription, you do. Okay, next. So there's other things. You cannot access in a timely manner, like in a weekend, a house call. This is a little bit would adversely impact the patient's medical condition. I think the biggest thing is, you know, if you can't do it, you document that it's covered. You know, you're just not making up this is an excuse for all occasions. They're not out to punish doctors, but they do want to know that you checked. So if the pharmacist is going to send the prescriptions in, and so the computer's going to say, this doctor's had 30 prescriptions, and no one's ever gone in line in his behalf. You know, then they're going to send you a notice. Do you know about this system? And then, you know, eventually they'll up the pressure on you. If you miss one of them, I don't think it's going to be a big deal. I could be wrong, but I know the people involved and so on, and I think they do not want to have, you know, if they make a mistake, they don't want to have doctors refusing to prescribe. And so, you know, if they go after a doctor because he missed one, that's going to be of a chilling effect on the state. And they promise the medical society and promise others they're going to try to be reasonable in the way they use this. And I believe they will try to. If they don't, then it's going to, the doctor will get hurt, but so will the patients get hurt, and ultimately the Department of Health will get hurt. Because the medical society initially opposed this bill, and they don't want thousands of patients calling in saying, the doctors aren't prescribing, look at this, what have you done? You know, so just, I can't promise. Next, yeah, go ahead.
We consult the registry online and it automatically shows up that we consulted it, or do I put it into the medical record?
It will be recorded that you consulted.
Okay.
You don't have to put it in the medical record. We discussed that at noon whether you'd want to or not. And I don't know, I guess your practice, they seem to want to do that. I don't think we're going to do that in our practice if somebody checks all the patients. But the question we haven't solved, well, what about somebody that was a call-in? And so they weren't in the schedule and they weren't checked. And so we got a couple weeks to figure that one out. You know, we may do something totally different. We may go online and find out all these names have to be typed in and we're just not going to, we have to do it some other way. I really don't know how we're going to do it. Maybe we'll have to hire somebody, but that's a problem. Next. All right, we go on next. So who can consult? We talked to you. The provider must have an access number. I think we covered most of this stuff. When the employee leaves, you have to remove them from the access list. You need to provide training. Confidentiality is really, really important. If you're going to be surprised, some of these people you're going to be sort of upset at, and just keep it to yourself. All right, next. All right, by July, the site should have full range of information you need. I hope so. It takes a couple of weeks to get all registered, so you should need to get the people registered in July so they can start practicing in August. I'm very concerned. I sent an email, again, I'm on the ISTOP committee, to the director, and I said, you know, how many people will be answering the phones? How many? I'm very concerned that the number, you know, all the providers getting the numbers and this and that and calling to get help is going to overwhelm the system. And I said, what happens if somebody is trying to get this done and they have a busy signal 20 times? Will they be exempted? I haven't heard yet. And I've asked them to calculate how much phone time they need for, you know, all the providers and so on, and the dentists too, you know, have to be part of that. So we'll see. I haven't gotten an answer yet. Yes?
Who's populating the original database? They're populating that from the controlled prescription pad?
Yes, it comes in, right.
It's coming in.
Yeah, they have a database now, but it's not up to date, and they only let you know if there's 2 different doctors prescribing in 2 different pharmacies. They don't let you know everything. And we've been arguing that that's, you know, you can consult it right now for that, but it takes a lot of work. Has anyone ever consulted it? It's a lot of work, and for not much information, because they have to have 2 different pharmacies and 2 different doctors, and it's about 2 months behind. So why, you know, it's not easy to go online. It takes time. So now they're going to have all the information. Yes?
So when this starts in August, how long will it go back? Like, what will it show us?
They say it's going to be 6 months. You know, I'm not... We'll see. They should have the information. We'll see. I mean, it's still not done with the programming. They're still not done with it. They have 4 programmers working on it. But he told me, that's what I want. He tells me what I want to hear. I say, wait a minute, we're getting time. We need time. When is it going to be? Early July. Well, how early? Says, so if they don't have it by July 15th, with the Medical Society, we're going to start to really, really put the pressure on delaying the August 27th, if they can do that. And that's our thing. We've telling you, and you've been promising and promising, and you haven't done it, and so I can't promise. I don't know what's going to happen. Okay? Yes?
And once you consult, then it's still that individual doctor's decision as
Right.
to whether or not what
Yes,
they're
correct,
going
what to do.
You're
Right. And I'm going to get to that in a second, actually. Let's go on. Yeah.
Quick question. With mobile technology, I can envision that on the 27th of August when this starts, and you get, there are 60,000 physicians.
100,000 people will have that. You know, all the dentists and so on, yes.
Oh, great. Can you imagine how hard this thing is going to crash the first day?
I know. Yep.
I'll put money on it.
I told you so.
We should actually start a pool, like a Super Bowl pool.
I was actually thinking of that. Like, we can start publishing. I can call the guy. If he doesn't answer me, the odds are 100 to 1. Do you want to bet? Do you want to bet? Do you want to bet? I don't have anyone on the other side. Yeah. But I really believe this is going to be a good thing. But
We've got a lot of things to work out.
yeah. Okay, next. All right, attitude. When you present this to your staff, be positive. This is going to help. You know, we're all, as doctors, we're that way. Our patients, we think this person isn't, they're not going to survive. But we don't usually. You're going to get through this surgery. We're going to be, let's be positive. And this is going to be helpful. And this is a good time for educating the patients. It's going to be in the news. It's a good time for changing the way we do things for prescribing opioids. And also other medicines, benzos and so on. Because we can blame the state first, and if you want to. So I guess make sure you have a plan that can work. You may have to hire additional staff. One of the questions we have is, we let people pick up prescriptions. Well, we have to check to do that. And I suggested we can pay for some of the staff by having people come in for quick visits and pick up the prescription. So, and maybe it'll be good medicine. In my office, all our group, which is every group, everybody agreed with me. My guess is that they won't all do that. But I told them, if you want to do it in August. Don't do it in a year. Don't start complaining next year. Think about what you want to do and set it up now while this is in the news. If you don't do that and just complain, too bad. I'll get my violin out. You know. So think about how you want to do it and then do it. I think this is a good chance that people come in, and I think that would be better medicine, and not just have them keep picking prescriptions up. But if you want them, you have to check them all. Next. Now, the 3 months prescriptions will help you. You know, B, stimulants, including adults, and you give a 3-month prescription. C, convulsive, D, chronic pain, A, panic attacks. And so this is going to reduce what you're doing, so they don't keep picking the prescriptions up. But I want to plead with you on this. Please don't do this until you're sure they're stable. Because don't, you know, okay, you're on Oxycontin, see you in a month, working great. Here's a 3-month supply. Please don't do that. All right, so make sure, see them regularly. Actually, see them in the office every month, and opioids, I see them every 2 weeks at first to make sure they're working, because if they're not working, get them off while you can get them off. Because after 6 months, you can't get them off. So really pay attention to them up front. Then when they're really stable, you can prescribe this. And then the other thing I'm thinking of doing is call them in for an unannounced pill count in urine drug screening. Sometime in the next year, tell them, I can give you every month, but I'm willing to give you a 3-month prescription. But sometime in the next year, we might call you in for an unannounced pill count and urine drug screening. Which would you rather have? And I think most of them would say, I don't want to come in every month. That would be fine. And then you can do that if you want. And that probably would tell you more about abuse than seeing them every month. But make sure that the work medicine is working. Yes?
Where's testosterone in this?
It's a controlled substance, so I guess it's fair too.
There's no code F for 3-month supply?
Wait a minute. I think there is.
Oh.
Yes.
What is it?
Code F is 3-month supply.
F, yeah, it is. I didn't know.
So,
Thank you. Great. Okay. As I say, anytime I give a talk, I always learn. That's correct. I just wrote it down in my notes. All right. Anything else I missed on these codes? Okay. Next. Electronic prescribing. I'm going to go over really quickly. It's going to be, next slide, it's going to be required in 2 years from now. And of course, once the electronic prescribing a controlled substance, you can get onto the site real time. You know, when you do the prescription, then it will take you to the site, supposedly. And so that will be available. And you can legally do that now, but your EMR is probably not set up to do it. And the ER companies are trying to, the state's working with the EMR companies to try to get them so they can do this. Another slide or two. Next. All right, so how do you sign an electronic signature? Well, you do it just like you go to get the ATM at the bank. You have to have 2 forms of identification. So one form is your card, and the other form is your number, access number. 2 forms of identification, right? And so that's what you're going to need for using this system for electronic prescribing. And so the electronic record, so your staff has to, when you're working the electronic record, when it's ready, then you can do this. Otherwise, you really can't. And the pharmacies have to be part of this. Now, so what are the 3 forms? You need 2 of these 3. And it's up to your electronic record and however your practice does this. One would be something you have, like a card, or maybe something in your cell phone, or a smart card, or some kind of a device, something that you do that you carry with you, that you know, they know that it's you. So that would be one possibility. The second one is fingerprint or iris scan. That's a second possibility. And the third one is a password or a challenging question or something. And we've done that with, I always forget my password, you know, so it asks me a question. So 2 out of these 3, and you don't, however your EMR is set up. So this is what's coming down the pipe. And so that it's safe. And there will be regulations for this electronic prescribing. but I think it will keep track, and then that will bring you into the site real time, so you don't have to look these things up forever. Next. So I think go on. Next is exceptions. Next, there's some changes. Hydrocodone is Schedule 2. Tramadol is 4. Next. Next. Okay, there's a committee that's advising, and we're recommending required CME. Next. Okay. This is somewhat unpopular. The Medical Society opposes it, but it's going to be the law, and you can stone me to death. I will confess I was in favor of mandatory CME. What the recommendation is going to be 2 hours initially when you get your next license, and for the, when I say license, for the prescribing controlled substances. And then every 2 years, another 2-hour course, or you can do a practice audit. Maybe check 10 of your charts, the people know for yours. That was my idea, and they seem to buy it. Because I think a practice audit teaches me more than all the CME. I can go, just go check them. I'm always surprised how badly I'm doing and how much I improve. Did I do a urine drug screen? Did I advise them that I had, this kind of stuff. So that's going to be the requirement. That doesn't sound too bad. However, if you prescribe more than 100 milligrams of morphine equivalent, you will be required to have an 8-hour course initially, not every time. Now that, let me tell you why. Next slide. Why 100 milligrams? Well, 60 milligrams of oxycodone equals 90 of morphine. So if you're on 80 of Oxycontin, 40 BID, or you're on MS Cotton 60 twice a day, you're over the 100. So, so why did they do that? And and I'm not saying this is right or wrong. I happen to favor this, but you could argue this many ways. People that are on over, not everybody over 100 milligrams is having problems, but most of your problems occur over 100 milligrams. If somebody is diverting and selling, they probably are on more than 100 milligrams. You know how they do. Well, doctor, this Percocet 4 times a day just isn't enough. I think I need, doctor, how about I'm waking up in the middle of the night, doctor, don't you think I need a long acting? And maybe they do. Maybe that doesn't mean they're selling. But if they're getting Percocet 10 TID and they're selling, they're not a very good businessman unless they try to up the ante. So, in other words, those over 100 are greater risk of selling. I'm not saying that no one sells under that. I'm just saying they're a greater risk. Secondly, overdoses. Those over 100 have a greater risk. Addiction. Those over 100 are more likely addicted. Can you have a problem on under 100? Yes, you can. The biggest problem you have is you're on opioids for 10 years that you probably didn't need for the pain. That's probably the greatest problem if you're under 100, and you're no better. But the problem is, so they're going to require an 8-hour course. And it's the same as the buprenorphine 8-hour. It's a different course, but I think it's going to be a good course. And I probably take 8 hours of pain course every year, and I taught them. So I think it's, anyway, you may not have any choice. But it might not be as bad as you think. It's going to be a lot more interesting, I think, than that medical liability course I'm taking right now, and I have to take every 2 years. And I have a couple more things to finish by the end of this month. The courses will be available online. It's going to be all kinds of different choices. And the course is going to be, not only it's going to be, I think it'll be a good course. I hope so. Not, I live in Dansville, you can come by my house. Get it. Next. All right, we're going to be, we have 5 minutes. Safe disposal, we won't hit. There's certain places you can dispose, and that's something that you can work on. Next. 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 All right, deaths are only the tip of the iceberg. Next. People are on many medicines. There's so many people on, they're on Percocet. I see a lot of people on multiple medications. And people, they're on Percocet, and they're mismanaging it. Their life becomes disorganized. Or they're smoking marijuana, and their grades go down, and they can't focus. So then they come and see the doctor. I have ADHD. I can't focus. That's all right, well, how about when you were a kid? Well, the work got hard. I must have had ADHD. I know I have it. My grades I really can't focus, doctor. I'm a junior in high school. I don't think I'm going to, here's some Adderall. So they take that. Of course, the doctor doesn't check the urine to see that they're using marijuana, causing the ADHD. And so they had the Adderall and they stored it. And then, doctor, I'm nervous all the time and I can't sleep. Oh, okay, here's some Xanax and here's some Ambien. And then they come and see me. Now, just next. So, the problem, we're talking about dying, but there's other problems. Of course, addiction, diversion, criminal activity, ER, falls, accidents. But probably the biggest problem is it interferes with life. These people are not doing well. And when I take them off the medicines, they're doing better. Doctor, I need more pain medicine. I can't do anything. I'm so nervous. So what do? I slay myself. I can't do anything. When you're on 200 milligrams of fentanyl patch, I can't do anything. Well, they're obviously, I take them off the medicine and they're out working or walking. So we're hurting these patients. When people get addicted, we get mad at them. But why don't we feel sorry for them and get them better? That's part of my message. One other thing, and I think I have 1 minute. Another. I guess, all right. And I guess when somebody comes in then, and they have, you find out they're going to another doctor, what do? Well, first of all, ask them why they're doing it. Don't get mad at them. You may be mad at them. Don't let them know that. Please. Why are you doing this? Well, maybe they have a good reason. You're giving Percocet 5 BID. I said, well, doctor, he gave me Oxycontin 40 BID. I said, well, how are you doing? Well, I went back to work last week. I didn't get a paycheck. I hadn't worked in 9 months. You treated me. Well, maybe you should go back to the Oxycontin, Maybe I should have given it to you. I don't, I'm just saying, ask them. But that's not usually the answer you're going to get. I just needed more. Well, maybe you have an addiction problem. Maybe this isn't working. Maybe we need to get you off of it. We need to refer you to a substance abuse counselor. I have somebody that can help you. We need to be positive. We do that. I'm sending you the best surgeon. How about, I'm sending you the best physical therapist for your pain problem. Best chiropractor. They're going to really help you. I have this wonderful massage therapist. Do we approach it that way? No. Nothing's working. Nothing's working. Oh, you can try this. Of course, that's not going to work. I have these substance abuse counselors that can really help. Suboxone is a wonderful medication, and I think we can put you on this and really, really help your pain and help you become more active and get control. And if you can be that way, you can use this as a therapeutic thing. You don't have to throw them out of your practice. Now, there are some patients that do need to be dismissed. Don't get me wrong. But think about it. Don't get mad at them. Get them help, for what they're doing. And I think if we look at that as part of medicine and part of what we're dealing with, and some of these people, when you see they're on medicine, you're like, I knew something was going on. But again, don't say, I got you. It's like, no, we can help you. It's just like when we, have you ever gotten an x-ray sort of, you should have gotten it earlier, or a lab test, and you're like, boy, high calcium or hyperthyroidism. I wish I had done that a couple of years ago. I wonder what it was. Well, look at it that way. And what do we'll get you? We'll get you an endocrinologist. We'll get you to a substance abuse. If we look at it medically, it's much better for everybody concerned. So I think, thank you very much. You've got to go. But if you have any questions, I'll be happy to stick around.
Dr. Silverstein?